cartographic views and the windows. Okay, so that's why it is very important to listen to this, because rest of the things, they depend on these talks. Okay, first and foremost thing for the neonatologists, the people who are doing the functional echoes, detection of the congenital heart disease is not the primary role of the neonatologist. If you recognize also, first you have to recognize what is normal. Only then you will be able to make what is abnormal. And if you find anything abnormal anatomically, please consult your pediatric cardiologist. It is very important. So this is a word of caution. So basic views we have been talking about. So there are, the thing is, the windows, why they have given the windows on the babies or patient chest. They have given this, the area, like to view the different part of the heart, what you have just seen in the heart anatomy. So this is to see the relevant areas of the heart in various sections. This is just a crude guideline, just a crude area they have given, so that you can fine tune and adjust to get the proper image. Okay. In pediatric cardiology and adult cardiology, they always tend to start with the subcostal views. In neonatology, we tend not to start with the subcostal views, because especially in babies who are not ventilated, who are awake and big babies, this is the view which irritates them the most, and they will start crying. And once they start crying, it's very difficult to get proper views. So what we do, we tend to start with the apical views, apical 4-chamber and 5-chamber views. And then we have parasternal views. Parasternal views are further divided into parasternal, low parasternal views and high parasternal views. That is at the nipple line. I will show you. So that is at the nipple line and below is low parasternal, above the nipple line is high parasternal. Low parasternal views are two: parasternal long axis view and parasternal short axis view. High parasternal views are all the views, or like ductal view, pulmonary artery view, pulmonary vein view, superior vena cava view, aortic, that's suprasternal view, what we call the suprasternal notch view. These are high parasternal views. Okay. Where to keep the probe, how to keep the probe, we will come to that. So, and then in the last, we do the subcostal views. Okay, subcostal views are again cross-sectional and longitudinal. We'll talk about that. This is for mainly seeing the superior vena cava entering the right atrium, and this is mainly to see the atrias, right atrium, left atrium, interatrial septum. Okay, so these are the windows we will do. The only thing is, whichever way you want to start, you start, but you have to complete the full cycle so that you have assessed the heart in total. That's why we should never miss the sequence. That is very important. Echo machines have been talked about. Don't worry. Again, I'm just stressing on this. Don't worry which machine you have, which button, because the basic function of the buttons remains the same. So you try to orient yourself to the machine, and you should be well versed with the buttons. So this is echo screen, basic echo screen. Okay. This is a Pical 4-chamber upright view. ECGs ideally we should have, but again, for practical purposes, we most of the time we don't do it. As we have already explained last weekend, this probe orientation marker is always on the left side of the screen. It is by convention. You have this scale, velocity scale. It is as per you have to adjust the area which you are doing the color Dopplers for. So this is a color Doppler window. Okay, and the sidedness is always, it correlates with your probe marker. For proper optimized image, as has been talked about, your 60% of this sector should be filled with the organ you are doing the imaging for. Okay, so this is very important. I have told you these things. Okay, for the depth, gain, color gain, these functions have already been discussed. M mode, pulse wave, continuous wave Doppler, moving up and down. These buttons are there. These are the basic buttons you should be well aware of on your machines. Pulse wave Doppler, continuous wave Doppler, again has been discussed in detail. Okay, so it was been talked about initially when we started, like, you know, the pulse wave upper limit is 2 meters per second, and this is the gate. So it calculates the velocity of the blood passing through this gate, and continuous wave calculates the velocity of the blood passing through the whole sector. Okay. And this Nicosit effect, I will just show you this video. We are doing this Dopplers with the pulse wave. Okay. And you see what I am doing, I am decreasing the range. And as the velocity increases from the upper range, you see the tip comes on the opposite side. And this is aliasing. This is the Nicosit effect. Again, the orientation of the probe, everybody knows this is the probe marker. It correlates with your probe orientation marker. Last week, I have shown on the baby also how if you rotate the probe 180 degree, how the chambers changed. So this is what is correlating. This thing you have already know, blood moving towards the probe, the color will be red, away will be blue. Now let me talk about the windows on the baby's chest. So first thing we will do is apical 4-chamber. So this is the area where the apical windows are there. Just below the nipple, around 4th to 5th intercostal space. This is the window for the apical views. Then we have the parasternal. This is the low parasternal views at the nipple line. Then we have the high parasternal views, or we also call them subclavicular views because they are just below the clavicle. Right subclavicular view, left subclavicular view. And then we have suprasternal notch, that is aortic view. And then we have subxiphoid or subcostal views. Okay, so these are the windows for different views. It is always a good practice, otherwise we have to remember that the probe marker, where it is pointing, left side, right side, head, foot. So it's always good to imagine a clock in front of the baby. So this is 12 o'clock, this is 6 o'clock, this is 3 o'clock, that is left side, and 9 o'clock, that is right side. So always imagine a clock in front of the baby. Now, henceforth, whenever I will be talking about in different windows where the probe marker is, I will be talking in terms of clock. Okay. So you please remember this clock in front of the baby. So now the basic views, as it was been discussed initially, they are divided in three main headings. One is 2D views. 2D view is like this. Okay. So like gray and black scale. In this, you are able to see upright apical 4-chamber view. Okay. In this, you try to orient yourself for the structure. Okay. Now, suppose if there is a preterm baby, 900 grammer, 27-28 weeker. Okay. And you have started doing the echo on the 3rd day of life. For the first week, in preterm babies, most of the ways, we tend to see the RA-RV is predominant chambers because of the physiologically high right-sided pressures. But if in that 3-day-old preterm baby, you start seeing LA-LV is dilated in a Pical 4-chamber view, then you start thinking that there is something which is increasing size of LV and LA. So the most common thing is the volume overload because of hemodynamically significant PDA. So that is what it is. So that's how you make yourself oriented for various diseases. And then if it is hypoplastic chambers, you get to see that. So you see the relative size of the various chambers in this. So this is how the 2D views will help. You put on the color Dopplers, you have to look for the blood flow across the valves, across the flow tracts, like mainly flow tract is left ventricular outflow tract, that is aorta, right ventricular outflow tract, that is pulmonary artery. And then you have any defect in the interventricular septum or interatrial septum, like VSD or ASD, you will see the blood flowing across that. And then you have M mode. M mode is to calculate the contractility and basically the measurements of the various organs or various part of the heart. Okay, we will talk about that. So now henceforth, for a few of the slides, you first try to concentrate on this part of your screen. There will be a video showing where you are going to keep the probe. And then on this part of the screen, there will be a video what you will see in that particular window in view. And then there will be a fixed picture here, which will be labeled. So we will start with a Pical 4-chamber and 5-chamber views. In 2D, you will tend to see structures. Okay, why I have written this pulmonary hypertension? In that case, your RA-RV will be dilated. You will be seeing interventricular septum. You will assess the intraventricular volume, and hence you will know whether there is hypovolemia or not, or there is any pericardial effusion in this typical apical 4-chamber and 5-chamber views. Now you see this video. This pointer is pointing at 2 to 3 o'clock position. Okay, and the probe is being kept just below the nipple and faced. This is what we call, the probe is swept, sweeping upwards. Last time I have told, sweeping upward means it is moving in the same plane of the ultrasound beams. Like this is the probe, and these are the beams. So it is moving in the same way where the beam is going. Okay. So I will show you how it is cutting the heart. Now you can see in this video, there is a apical 4-chamber view, and you see this this pointer probe orientation marker. It is coinciding. Okay. So as we know, this is on the left side. So this is your LA, LV, RA, RV, interventricular septum, interatrial septum. These three are the pulmonary veins, and this is the cross section of the descending aorta. Because if you cut the heart, this is how your aorta will be in cross section. The aorta will be in cross section like this. Okay. Now you can ask me why this thing is upright, why this probe orientation marker is down here. In adult cardiology, they put this inverted up, but this is inverted image. What we have done is a apical 4-chamber view. We have made it upright, anatomically corrected, because as we all know and shown, the ventricles are down, atria are up. That's how we imagine the heart. This is your heart, okay, and this is how I'm seeing it. So that's how the heart is being cut. So ventricles are down and atria are up. So that's how you put the probe, and this is what you will see in upright section. Okay, and then you have a apical 5-chamber view. So the probe pointer is rotated clockwise from 2 to 3 to 4 o'clock position and is swept up. Whenever I will be talking about sweeping, it is always in regards of the foot of the probe, never as a tail. Always the foot of the probe will be sweeping up or anteriorly. And what will open up is this, what we call as LVOT, left ventricular outflow tract. This is aorta, and this is your aortic valve. So you have LA, LV, RV, RA, and the aorta has been opened up. So this is a apical 5-chamber view. So your pointer is, you start with 2 to 3 o'clock position. Just below the nipple, you have a apical 4-chamber view. And when you rotate bit clockwise and sweep the probe upwards, this is your probe pointer at, okay. And if you sweep the probe up here, this is how it is, a apical 4-chamber. These are your eyes. If you sweep up, you will start seeing aorta. So this is your apical 5-chamber view. Okay, this is how it is being cutting. I showed you with this knife. So basically your ultrasound waves are knife. This is how your heart is being cut, like this, and the cut heart is being shown directly in front of you, a apical 4-chamber view. See, this is the beating heart, and this section is being cut. As it is done in adult thing, that's why it is inverted. Ours was upright, it is inverted, but this is a apical 4-chamber view. So it is something like the apple is being cut like this, the way you are seeing in the screen. Okay. So then we do the Dopplers. So we have to see the flow across the tricuspid valve, mitral valve, and flow through the major vessels, because we have to calculate the velocity, and that velocity is being calculated by velocity time integral. What is this velocity time integral? I will tell you in bit, because we use this to calculate the cardiac output, and then we assess various functions. And now, why I've written this thing in red? It is not a good view to see the flow across the atria and the ventricles, because see, just let me go back. Okay. Now, the basic principle of ultrasonography is if you want to calculate the flow of the blood, your ultrasound beam should be in line with the flow. And if you want to calculate the size of and or defect or anything, your ultrasound beam should be perpendicular because the temporal resolution should be good. So now suppose if you are in this view and there is VSD in this, the flow of the VSD is from left to right. Okay. So if I am calculating, my beam direction is like this because this is a probe orientation marker. Okay. So if my flow is like this, so my beams are perpendicular to it. So they are against the basic principle of sonography. And if I want to calculate the size, it is in line. They should have a perpendicular. So this is not a good view to calculate the size and see the flow across any atrial or ventricular septal defect. I will be able to see, okay, there is a defect, but this is not a good view to calculate the size and do the Dopplers of the flow through the defect. This you should bear in your mind. Okay, so this is what I'm doing a color Doppler across the tricuspid valve. Okay, this is my probe orientation marker. The blood flowing from RA to RV is red, and blood flowing from RV to RA, that is a tricuspid regurg, will be blue. So you can see a trickle of blue here. And if I want to calculate the TR jet, I have to put my continuous Doppler here towards the atria. And now this is the Dopplers done for the mitral valve. Again, the MR will be blue and the normal blood flow from LA to LV will be red. And these are how the Dopplers they look like. And this is a Pical 5-chamber view. You can see the blood flow through aorta. That is blue because it is moving away from the probe. And when I want to calculate the velocity, I will put a pulse wave Doppler here just above the aortic valve in the middle of the aorta. I will get a velocity pattern like this. And when I encircle that in the machine, I will get the VTI, that is a velocity time integral. Basically, the velocity time integral is that gate. It calculates only a part of the velocity of the blood passing through that aorta. So when we do the cross-sectional size of aorta, what it does, it averages out, okay, averages out that this much of the blood has passed through at the given time section. So it integrates time and velocity together, and that's what we call as velocity time integral. And that's why we use it in this formula of calculating LVO, left ventricle outflow. Those are the things we don't talk in basic echo workshops. We do it in the advanced echo workshops. And when you sweep it further up anteriorly, as it was been told, you will see the aorta, which was like this, it is gone, and you started seeing another vessel overlapping that at right angle to that. So that crisscrossing is there. So that rules out. So this is what? This is your pulmonary artery. It is anterior to your aorta. Okay. And when you see this, that your aorta is gone, and at right angle another vessels appear, that is pulmonary artery, it rules out your TGA. If you start, so you will never see aorta and pulmonary artery in the same plane. If you start seeing aorta and pulmonary artery in the same plane, we call it double barrel view, and that is for DTGA, TGAs, transposition of great arteries. Okay. And now you can see, if you sweep it further anteriorly, upward the foot of the probe, you start seeing this vessel at right angle to the aorta, which was like this. So this is your sweep, a Pical 4-chamber. Okay. You have a Pical 4-chamber. Then sweep upwards was a Pical 5-chamber. And further you sweep, your aorta will be gone, and you will start seeing your pulmonary artery. So next comes the parasternal views. So in parasternal views, low parasternal views, and in low parasternal views, we have parasternal long axis view and then parasternal short axis view. Again, in parasternal long axis view, we will have 2D. Okay, again, I will show you how the heart will look like in that. We look for the structures. And then in this is the view, we can calculate the size of the VSD and the blood flow across the VSD. And we do M mode here to calculate the cardiac contractility, that is FS, fraction shortening. That will be how to do it practically, how it has been done, will be shown tomorrow in the demo sections. So now see the pointer of the probe. Probe is kept at nipple line. Pointer of the probe is facing at 11 o'clock position, that is towards the right shoulder. And now you can see this probe orientation marker is up. So only for a Pical 4 and 5 chamber view, it was down. Otherwise, it is still on the left side of the screen and it is up. So what it is being done? The heart is being cut longitudinally. Okay. So this heart, which is like this in the chest, is being cut longitudinally like this. Okay. And hence you are seeing anterior RV, which is anterior RV wall. RV is the most anterior part. RV chamber, right ventricular chamber, interventricular septum. This is LV, posterior wall of LV. LA, this is mitral valve, and this is your aorta. And this is your aortic valve. So these are the things. So your heart is being cut. You can see it in the chest. So this is how you have kept the probe. Heart is lying in the chest like this. And this is your standard plaques view. That is parasternal long axis view, which is standard. This is how it is cutting the heart within your chest and how this will look like. Anterior wall of RV, RV chamber, interventricular septum, LV chamber, mitral valve. This is left atrium and this is aortic valve and aorta. And this is the animation, which is just see, it overlaps, how it is being cut and put in front of you. So your heart is cut longitudinally in this. Okay. So this is, we use this view for many things. Okay. So this is a plaques standard view. And then in plaque standard view, we have two sweeps. One is sweep up, I will show you, that is for the pulmonary artery sweep, and sweep down, that is tricuspid valve sweep. So that I will show you. So this is how, this is the animation drawing, and this is in reality what you will see in your echo. So see, this is how the heart is being cut longitudinally and how the heart is being presented in front of you in parasternal long axis view. So this is something like banana split ice cream. Your banana is being cut longitudinally. This is how it is, the heart is being cut. And when we put a color, Doppler window, we will see this is interventricular septum. Okay. Now, if you have a VSD, now you see, this is your probe. Okay. So if your blood is, if there is a VSD and your blood is flowing from LV to RV, so this is towards the probe, it will be red. And it is in line with the ultrasound beams. So you can calculate the Dopplers, do the Dopplers of the defect flow in the defect. And if there is a defect, it is in this septum. So the beams are perpendicular to it. So you can calculate the defect. So in this view, you can calculate the defect, VSD defect size, and do the Dopplers of the flow of the blood in the beam. And if the blood flow is from right ventricle to left ventricle, it will be blue because it is away from the probe. So all left to right shuntings through the defect, VSD, PDA, ASD, PFO, all left to right shuntings will be red. All right to left shuntings will be blue. All the flow in the major vessels like aorta and pulmonary artery in all the views will be blue. It is just a practical tip. Okay. And the regurg in that will be red. And the regurg at mitral valve and tricuspid valve will be blue. So just remember this. And this is again, we are doing M mode. Okay. This motion mode line is being passed through. This is the mitral valve flaps. This is your LV cavity. And this is being used to calculate your fraction shortening. And that is for calculating the contractility of the heart. This is being done in this plaques view. Okay, so I talked about the sweeps. See, now what I'm doing, I'm sweeping towards downwards. I will show you on the mannequin also. So this probe is being swept downwards. You see this tricuspid valve. So when you sweep from the standard plaques view towards the foot, it is tricuspid valve. Now it is again standard plaques view. And then if you sweep up and you start seeing this pulmonary artery. And this is MPA, main pulmonary artery. This is RPA and this is LPA. So this is your standard plaques view. And when you sweep up, you saw that this vessel aorta is gone, and you start seeing another vessel coming from upside down at right angle. So this sweeps again rule out your TGA. If it is a TGA, you will start seeing aorta and pulmonary artery both in the same view. In the last day, you can see that TGA pictures, it's a double barrel view. But when you start do this sweeping and you start seeing that, see this pulmonary artery, now that aorta was gone, so your TGA is being ruled out. Okay, now you see, this is standard plaques view. When I sweep up, you see, when I sweep up, you see my hand, how it moves. My foot of the probe is swept up. The standard plaques view which was there is gone, and you start seeing this vessel which is perpendicular to the aorta, and this is pulmonary artery. And this how you can put the color and do the Dopplers of pulmonary artery. This is MPA, main pulmonary artery, RPA and LPA. You can see the both. And next sweep, you see my hand is moving downwards. Okay, this foot of the probe is down. You start seeing the tricuspid valve. And this is the view in which you can do, if there is a TR jet, you can calculate the TR jet by putting the continuous Doppler just in between the jet towards the atria. So that was regarding parasternal long axis view. This is what I will put a color. Again, TR jet will be seen blue in this, because from RV, if it moves to RA, this is a probe. So it is against the probe. Direction is opposite to probe. So that's why it will be blue. Now we come to other part of low parasternal views, that is short axis view. So the heart has been cut in cross section. So in this, in 2D, we will have a sweep from the base of the heart. I will show you in animation also. So this is the base of the heart. So from this base of the heart, the probes move down. So then comes the mitral valve here. Then comes the papillary muscle, mitral valve, papillary muscle, and apex. Why this sweep is important? In this, first we will see the base of the heart, in which it is being cut at this level. So you will start seeing the entry of the aorta. So we will have the tricuspid valve there. Okay, then we will check for the mitral valve, then the cavity of the left ventricle, papillary muscles, and then we will see which is the apex forming chamber. Why it is important? Because we have to notify, because if it is a hypoplastic left heart, only then your apex forming chamber will be right ventricle. Or if you have some very severe PPHN or some obstructive lesion of the right side, your RV is so big that it will have, RV will overlap your left ventricle. So then only your left ventricle will be right ventricle will be your apex forming chamber. Okay. Then again in this, you can do the Dopplers for VSD, TR jet, and then you can do FS, fraction shortening, to calculate the contractility. So in this, you see my probe. See, in plaques view, the pointer was pointing at 11 o'clock position. Now I've rotated it exactly to 90 degree, and now my pointer is pointing at 1 o'clock position. In the same place, started from the base, and this view you will get. This view we call it Mercedes-Benz sign view. In this you have this aorta, aortic valves. Okay, this is pulmonary artery. This is pulmonary artery. This is RV, RA, tricuspid valve. So you can do tricuspid regurg here also. You can check. This is your RA, this is your LA, and this is your interatrial septum. This is what you will see. Okay. This is how the heart is being cut cross-sectionally like this. Okay. And this is what you will see in your parasternal short axis view. See, this is beam which has cut the heart cross-sectionally in short axis. And this is the base view. From the base you will see, and this is what is Mercedes-Benz signs view. And this is the sweep from the base of the heart going towards the apex of the heart. This sweep is there. Okay. And hence this is something like fruit chart. The banana has been cut cross sectionally, apple is cut like this. Okay, this is your short axis view. And then when you see, I have kept this pointer at 1 o'clock position, and I'm just moving the hand from the base towards the apex. The next view you will see is mitral valve view, and we call it as fish mouth view. See, your mitral valve is opening like a fish. Okay, so this is your LV, interventricular septum, and this is your RV. This again is good view to see the VSDs. Okay, and again you can see the flow is across the ventricular septum will be in line the flow, the direction of the ultrasound beam, and again it will be perpendicular, so you can calculate the defect size also. And next, when you sweep down, you will see this papillary muscle view after the mitral valve view. Again, this is the left ventricular cavity. These are the papillary muscles. Okay, and you can again see, and this is the view in which you have to see what is the positioning of interventricular septum, especially in PPHN patients. And you can continuously see my hand, which is being sweeping down towards the apex. And if I sweep it further down to the apex, this is how the apex will look like. This is the apical apex of the LV. So my apex is formed by LV. RV is gone. It becomes very small. So it confirms that it is not a hypoplastic left heart. And then again, you can put a color window on the interventricular septum to see if there is any defect. And if there is any defect, again, left from LV to RV, left to right shunting is red, right to left, RV to LV shunting will be blue, because it will be again opposite to the where the probe is there. Okay, so it remains the same. Now we'll come down to the high parasternal views, that is in the upper 1/3 of the sternum. We also call them subclavicular views. It includes your ductal view, pulmonary artery view, pulmonary vein view, SVC view, superior vena cava view. This is basically to calculate the diameter of SVC. And then we have a suprasternal notch, that is aortic arch view. So these are the views mainly we do in high parasternal views. Okay, so we will start with the ductal view. Normally, the ductal view is left subclavicular view. Okay, where to keep the pointer I will talk. Okay, but in newborns, the chest is so small and is so straight that even from the right subclavicular, okay, if you sweep your probe from here towards the left side like this, you will get ascending aorta, arch of aorta, and descending aorta in one view. But ideally, the ductal view is in the left subclavicular view. You see, now for ductal view, pointer is pointing at 12 to 1 o'clock position. 12 to 1 o'clock position. This probe orientation marker is still up. So it is kind of modified short axis view. Okay. So as it was been told in anatomically presentation, the PDA starts from where the descending aorta starts. From descending aorta, start of descending aorta, it goes up and join the pulmonary artery, that is MPA, towards the left pulmonary artery side. So this is your cross-sectional aorta, ascending aorta, where it started. Then you have this MPA, this is RPA, LPA, and this is your descending aorta. When I put a color in this, now you see, this is pulmonary artery, this is descending aorta. So if the PDA is open and there is a flow, and the flow is from left to right, that is from aorta to pulmonary artery, it will be towards the probe. So that's why I told it will be red. If it is totally right to left, that is complete right to left flow from pulmonary artery towards the aorta, especially in severe pulmonary hypertensions, it will be blue because it will be away from the probe. And if it is moderate pulmonary hypertension, you will see a PDA which is open and it is shunting bidirectional. Okay, so as you can see, two blues, but there is no red in between, so there is no PDA. But in this, you see descending aorta, pulmonary artery, and you see this red jet going up. So there is PDA and it is flowing predominantly left to right. That's how you will see the PDAs in this ductal view. Okay, now you see in suprasternal notch how it happens. Again, the probe is there in suprasternal area. Okay, in newborns, it becomes very difficult sometimes, especially in ventilated babies, because the neck is very small. Pointer again has 12 o'clock position. You see the ascending aorta, descending aorta, and the three branches. Okay, how you will look that? See there. Pointer is pointing at 12 to 1 o'clock position in the suprasternal areas. Probe orientation marker is still up. Okay, and this is how you will see arch, the ascending aorta. These are the three branches: brachiocephalic, left common carotid, left subclavian, and this is the descending aorta, and this is the isthmus part just after the third branch, and this is aorta, RPA, right pulmonary artery, because it was been told in the anatomy that when aorta goes like this, the pulmonary artery divides into two, RPA and LPA. So when you cut aorta longitudinally like this, okay, you will have branching of pulmonary artery like this, so it will be in cross section. So when you cut aorta in longitudinal sections like this, what you're seeing here, so your pulmonary artery will be cut in cross section. So this is your aortic arch view. You put in the color and you see there is a laminar flow. You can do the Dopplers here by pulse wave Doppler. This is how the Dopplers you will get. This is again to calculate the and see that if there is any, somebody asked. So this is the view to look for coarctation of aorta. If you have a coarctation, the most common part is this isthmus, where this third branch arises, and PDA also rises from this part most commonly. So this is isthmus part, and most commonly the coarctation occurs here. So if you have a coarctation and put the color, there won't be any laminar flow like this. You will see the narrowing of this part, and after the narrowing part, you will see a jet of the blood flow, which will look like yellow or orange. And you do the Dopplers there, your peak velocity will be more than 2 meters per second. So if you have a peak velocity more than 2 meters per second, you have to do it then Dopplers with a continuous wave. More is the velocity, more is the constricted part. So this is the view you do for rule out coarctation of aorta. And then we have left subclavicular region. So this is the left subclavicular, your left side, just 0.5 centimeters below the clavicle and around left side of the parasternal. You will have pulmonary artery view and pulmonary vein view. See, now your probe is there, but now probe or marker is at 3 o'clock position. Is facing your left shoulder, 3 o'clock position. Your probe orientation marker is still up. You see this vessel like this. This is your MPA, pulmonary artery, main pulmonary artery. This is your right pulmonary artery. This is your left pulmonary artery. And as you can see, because they are in both pulmonary artery and aorta, they are at right angle plane. So if you have cut the pulmonary artery longitudinally, you are seeing the aorta in cross section. And this is your cross sectional aorta. Okay, so this is your main pulmonary artery, RPA, LPA, and you have a cross section of aorta. So this is also known as pent leg view. It is something like pent. Okay, you put on the color, so you can do the Dopplers of MPA, LPA, LPA, and RPA both. Individually, different branches Dopplers you can do, and you can do the Dopplers of pulmonary artery in this view. Hence, you can rule out your pulmonary stenosis and pulmonary regurg also. So this is now your pulmonary vein view. Again, the probe is being kept at the same place in the left subclavicular area. Pointer is pointing towards the 3 o'clock position, that is towards the left shoulder. The only thing is, it is same where you do the pulmonary artery view. But as you can see, what I have done is, I have did the sweep of the base of the probe, the foot of the probe towards the foot downwards, that is posteriorly. You start seeing this LA, left atrium, and this is that what Dr. Dinakar also showed, the crab view. 4 pulmonary veins entering into your LA. This is left lower, left upper, right lower, right upper. So when I put a color in this, you start seeing 1, 2, 3, and 4. So upper two, right upper and left upper will look as blue because they are moving, the flow is away from the probe. And lower two will be red because the flow is towards the probe. And this is known as the crab view, the pulmonary vein view. Okay. To look like, and there was a trend to calculate the SVC out, the cardiac output through the SVC flow. So for any flow outputs, we have to know the size of that vessel and then the flow velocity, that is VTI through that vessel. So VTI we calculate, SVC VTI we calculate either from right subclavicular view, or very easily we can do it in the subcostal view. I will show you the subcostal one, which is easier. Okay. But so this is how, like, the pointer, probe is right subclavicular and the pointer is again pointing at 3 o'clock position. You will see the SVC coming from up downwards, but this is a bit difficult view. So we will, instead of that, we'll go for subcostal view. But to calculate the size of the diameter of SVC, okay, so this is a kind of high parasternal views. It is just above the nipple line. That's why it is high parasternal views. The pointer is again pointing at 12 o'clock position, and then you have to sweep the foot of the probe towards the right side. I will show you that, but this is how it is. Pointer is pointing at 12 o'clock position here, and sweep the probe towards the right side. So this is above the nipple line. Put the probe, pointer is at 12 o'clock position, okay, towards the left side of the sternum, and sweep the probe towards the right side, the foot of the probe. This is how you will see. Again, you can see the pointer probe orientation marker is above, and this is the SVC which is entering into your RA. And here we calculate the size of the SVC by M mode. Okay, this is how we do it. Maximum size and minimum size, because the size of the SVC varies with the respiration. So we have to take the mean of it. Okay, now we will talk about the subcostal views. So subcostal views are, one is cross-sectional view, what I am showing you. This is just below the xephisternum. You have put the probe, pointer is pointing at 3 o'clock position. So this is a cross-sectional view, 3 o'clock position. And one thing you will notice that I have put the probe orientation marker down below. Okay, this is again, this is some of the people do it. I do it myself, because when you see the heart, okay, when you see the heart like this from the subcostal view, the atria which is nearer to you is right atrium, away from you is left atrium. So if it is inverted upside down, like probe orientation marker is here, then it will be upside down. So just to anatomically correct it, I bring the probe orientation marker again down, and then put the probe in the subcostal region, pointer pointing at 3 o'clock position. This is what I will see. This is RA, LA. These two pulmonary veins you are seeing entering here, and this flap you are seeing is the PFO. This is PFO. Okay, this is how, when we put the color, you can see the flow of the PFO. Again, from left to right, like it is from LA to RA towards the probe, it will be red. And anything which is moving from RA to LA, it is blue. And here, if you see the flow through the PFO predominantly right to left, you have to rule out one defect, that is TAPVC. You have to rule out that. Okay. And then for SubCoSPC, again, pointer is pointing at 3 o'clock position. As you can see, what I did, I sweep it up. So anterior, I sweep the probe up. You start seeing this red flow, SVC, entering into your RA. In here, if you put a pulse wave Doppler, this is how you will get the VTI for the SVC. So in the same cross-sectional subcostal view, you will tend to see the do the Dopplers of SVC entering into your RA. And now this is again subcostal longitudinal view, sagittal view. Your pointer, instead of 3 o'clock position, is now pointing at 12 o'clock position in the same subxiphoid region. And if you sweep the probe towards the right side, you will start seeing this IVC. IVC entering into RA. And SVC and IVC, when they enter into RA, they always fan out like this. They fan out. That is a very particular thing about SVC and IVC. And it is through the liver, and you will see this hepatic vein here. And again, IVC again is variable with the respiration. Okay. And when you sweep this probe towards the left side, you will start seeing this vessel, which is pulsatile. You see this is your spine. Okay. And then there are two branches here, celiac trunk and SMA. So this is your abdominal aorta. So if you sweep towards the right, it is IVC. Sweep towards the left, pointer again same at 12 o'clock position. Towards the left side, you will start seeing your abdominal aorta. And the probe orientation marker is up there, here. Only the probe orientation marker is down in two views, which I've got. One is a Pical 4-chamber, 5-chamber, and then in subcostal atrial view, where I want to see the atria. For the rest of the views, it is on the upper side of the screen. So it means all other views are inverted. So my friends, sometimes, I know it's in one go, it becomes very difficult. There are issues with that. Okay. But you have to keep learning. Okay. You have to churn yourself very nicely. And you have to keep on doing the hard work. That is very important. So it is not just by seeing and seeing the anatomy and seeing the views and the windows. You have to practice, and we will do that. You people will do that for the next week. Okay. But read the instructions very stringently and try to correlate. Okay. Don't do the hard work without correlating the instructions well. So this is, I know this is not relevant now. It is basically in newborns, what we do is ductal study, pulmonary hemodynamics, that is PPH, and systemic perfusion, that is your shock. And these are the different views in which we do different readings. But this will be useful only for you people if you attend your advanced workshops. Then you tend to, this is for how you do the PDA's hemodynamic significant label, how to classify your PPH and mild moderate severe, and then how to assess whether baby is in shock, cardiac contractility is less, and all. So that's why we do see a Pical 4-chamber, parasternal long axis, parasternal short axis, ductal view, arch view, subcostal view. So we go in a sequence, in a cycle, to complete the whole study. Whether we are doing for anything, it has to be in the cycle. You have to complete the full cycle. So if you want to have further things, like there are 2 or 3 books which are available, you can contact at this number and you can get these books. This is for, in this only heart echoes is being mentioned, and in this you have the whole point of care ultrasound for head ultrasound and everything. So thank you very much.